Good afternoon, everyone, and thank you for joining today's presentation. Please take a minute to orient yourself to the screen. Virginia gave us a bit of an orientation, but I wanted to review it one more time. If you have a question, please use the chat function in the lower left side. Technical questions will be addressed as they come in, and content questions will be addressed towards the end of the presentation. If you would like to download the content of this presentation, please use the triangle icon on the top right. Live closed captioning is available at the bottom of the screen. My name is Chris Duff, and I'm a disability practice and policy consultant who has been working with the Lewin Group on the development of disability competent care and related training webinars and materials. On behalf of the Lewin Group, I'd like to welcome you to our 2017 Disability Competent Care webinar series. The Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services has contracted with Lewin to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated, coordinated care to Medicare, Medicaid enrollees. This series will consist of 7 webinars running on consecutive Wednesdays at this time through March 22nd. All the webinars will be recorded and are available along with a PDF of the slides at the Resources for Integrated Care website with the web link on this page. In 2013, we published a comprehensive disability competent care self-assessment tool describing disability competent care, and we have since produced 25 webinars on the topic and numerous supporting tools and documents. These are also on the RIC website. The DCC material has recently been revised to be more accessible to users and reflect the further development of the field. It is now structured in 7 pillars of disability competent care. In this series, we are introducing these 7 pillars in separate webinars. We will be allowing at least 15 minutes at the end of each for discussion and questions. We would like to solicit your opinion on this series, as well as past webinars and supplemental resources. Please take time to complete our survey at the end of this webinar and send us your ideas for future topics and content. Contact information is listed at the end of this presentation. Today we will present an overarching definition of disability and some background information to inform your understanding of the population of adults living with disabilities. We will define disability and its impact on those who live with a disability. We will be hearing from a couple of persons describing their experiences interfacing with healthcare providers. We will follow that with an overview of the 7 pillars of the DCC model. Most people have viewed disability as a medical condition, such as blindness, spinal cord injury, and others. Over the last couple of decades, this definition has evolved to reflect the one on the screen, focusing instead on the impact upon those living with a disability. The DCC model is based on looking at disability from a function-based perspective, understanding and addressing the limitations experienced. If you know one person with quadriplegia, the next one you meet with quadriplegia will certainly be different. We all vary by age, gender identity, race, ethnicity, socioeconomic status, sexual orientation, function, and a raft of other factors. Disability competent care requires that we understand the participants as individuals Each will experience their disability differently. Each has varying disabilities and chronic conditions, and each will have different functional limitations due to their disability. Functional status identifies the impact of the disability, whereas diagnosis identifies the cause or source of the disability. Functional limitations are identified through standardized tools assessing activities of daily living, commonly referred to as ADLs, or instrumental activities of daily living, referred to as IADLs. You will hear of these throughout this webinar series. These are standardized tools that have been in use for many years and serve to provide a foundation for identifying the specific supports a person needs. As you can see in this slide, ADLs include self-care tasks such as feeding, bathing, and dressing. IADLs include tasks that enable an individual to live independently in the community, such as using telephone or communication device, homemaking, meal preparation, and others. For example, a diagnosis of spina bifida doesn't indicate what an individual can do. Physical capability and capacity, along with the living environment, are indicative of varying levels of functional dependence. Thus, the need for ADL and IADL assessments. Disability types are commonly broken down into 4 clinical categories, usually for purposes of program or service eligibility. These are most quickly accessed, when analyzing medical records or claims history. Examples of physical disability are a spinal cord injury, multiple sclerosis, or other mobility impairment. Examples of intellectual or developmental disability are autism, cerebral palsy, or other intellectual impairments. Examples of sensory impairment are a vision or hearing limitation. Examples of behavioral impairments are major depression, behavioral limitations, and chemical health challenges. It is also important to understand the differences of being born with a disability and acquiring a disability later in life. For persons born with a disability, that is all they have known, and it's quote-unquote normal to them and their family. Understanding and self-acceptance is seldom an issue. Conversely, for those who acquire a disability after they and their family have begun to establish their identity, it is a very different issue. These individuals often struggle to understand and integrate this change into their lives and self-image. Lastly, it is important to note that individuals rarely fit into one category. For most experience components of one or more. Sometimes the coexisting or co-occurring disability is a direct result of a primary disability. An example of this would be depression or anxiety a person with a physical disability may develop due to challenges interacting with the healthcare delivery system or even friends and the broader community. Most all of us will experience some decline in function as we age. For me, I need glasses and find myself needing to write things down more for recall. Of course, though I'm still in denial, I've been told I am losing my hearing acuity. Well, these are not commonly disabling when they first present. They become functional impairments as they become more severe. Lastly, it is important to understand the distinction between visible and invisible disabilities. Visible disabilities are those that are readily evident to others, such as spasticity or the need to use a wheelchair. Invisible disabilities are those that are not as readily evident to others. They include hearing loss, diabetes, arthritis, and many mental illnesses. Because many live with this invisible limitations, it is extremely important to inquire of the individual whether they have any disabilities or limitations they would like you to know about. Alternatively, you could ask if they have any accommodation needs. This is especially true when interacting over the phone, where you don't even have the benefit of a visual image. In 2015, an estimated 14% of non-institutionalized male and female of all ages and races, ethnicity, and education levels in the United States reported a disability. These statistics were calculated by Cornell University using the U.S. Census Bureau's 2015 American Community Survey. Other governmental estimates have the number as high as 20%. Therefore, between 40 and 50 million persons in the United States live with a disability. Looking at this from a different perspective, there are 7.5 million dual-eligible individuals under age 65 in the U.S., most of whom are dually eligible due to disability status. Let me clarify here, by dually eligible, I mean they are eligible for both Medicare and Medicaid. It is also important to look deeper than just the incidence of disability. Research has shown these individuals experience material hardship, including difficulty paying rent or utility bills, food insecurity, limited access to medical and dental services, limited options for transit, unemployment or underemployment, family and social relationships, social opportunities, and meaningful activities. They are also disproportionately represented in racial and ethnic groups and are growing in number as the population ages. Building upon the last slide, research has demonstrated that persons with disabilities experience significant health disparities. They experience worse outcomes and are less likely to receive recommended care. They experience delays or barriers in accessing necessary care. They have lower levels of receiving recommended health screenings, such as breast and colon cancer screens, and cholesterol and diabetes care. Many have not had an annual dental visit, which is commonly due to accessibility issues. They have limited knowledge and access to sexual health information and others. It is our hope and intention that this and related disability competent care trainings will begin to address these disparities. The National Academies of Science, Engineering, and Medicine are about to release a report on social risk factors and their impact on Medicare and Medicaid costs. As the government moves from fee-for-service payments to a variety of value-based payment models, it has been demonstrated that social factors need to be accounted for in value-based payments, for diagnoses alone does not fully reflect the cost of care. This report identified 5 domains of social risk, which have certainly been well known for years by those living with a disability or those of us working with the population. The STARS quality metrics and measures are one strategy being used to address this concern. Along with the social factors, it is necessary to be aware of disability-related biases. These biases can often inhibit listening to and learning from the participant. Together, you and the participant can develop plans and strategies that will result in the best care and minimize adverse health outcomes. This will be addressed in much greater detail in the 3rd webinar of this series. At this point, we're going to show a short video. Please remember to turn on your computer's sound. These vignettes that we're going to show in this webinar and some of the others were developed by Greta in California. They show people talking about their experiences interacting with the healthcare system. The first is Jim Brett, who was born with spina bifida. He grew up outside of New York City and went to college in Southern California. Jim moved to the East Bay of Northern California to take a job with the Berkeley Repertory Theater as a sound engineer. He has recently opened his own business serving the film industry. In this clip, Jim is referencing the biases we all bring to working with people with disabilities. He's asking us to listen to the experience of your participants and together build a plan of action.
Here's the key here, I think. So there's many ways to deal with certain situations. But your patient that has a chronic illness has been dealing with it 24/7. And they're rolling into walking into your room. And it's like, and if you knew how to trust their judgment versus your years of experience in medical school and collaborate with them, I think you get much better results. If all of your knowledge about kind of the world and techniques of dealing with folks has been based in medical school and has been based basically on people who are bipeds, people who are walking around who don't really have any active disability going on, then you're missing out on some really important information. I think that looking at your patient with a disability as a resource, not a problem, would be a really great place to start. Ask them and learn from them, and then share that information.
I think Jim explains the situation well. I think this is also a good point for me to reference some language issues. Jim used the word patient at one point in his video. I tend to use the word participant. Client is also used in the field. What people with disabilities generally prefer is a more active reference. So being a patient kind of implies passive to the professional who's telling them what they need. We use participant to reflect their active involvement with their care team. As most of you know, well, there are many challenges in the existing healthcare delivery system. This slide describes the key challenges and their results. Presently, care is commonly reactive and proscriptive. It is fragmented, as exemplified by the fact that most persons with disabilities see multiple specialists, though have limited access to experienced primary care. Many settings of care are inaccessible to some degree, from getting into the building to as simple as being able to maneuver within an exam room. Lastly, care is increasingly becoming standardized and uniform. While this is often good, being based on extensive studies and research, most persons with disabilities have extenuating situations or issues that may require modifications from this standardized care. The result of this care is extensive avoidable costs, both financial and personal. Poor care results in avoidable costs and often misery on behalf of the participant. Payment incentives are misaligned, leading to transfer of costs to other payers, providers, or even the participants. Lastly, as mentioned earlier, there is a very limited availability of experienced primary care practitioners willing and able to see persons with disabilities. At this point, I will move into the disability competent care model itself. As the statement says, it is designed to meet the needs of the participant and address their resulting functional limitations, not just their diagnoses or conditions. This slide describes basic tenets of the model of care. It is participant-centered and delivered by an interdisciplinary care team. It focuses on the maintenance of health, wellness, and life in the community, and as the participant chooses. The model recognizes and treats the individual as a whole person, not just a diagnosis or another descriptor. It is designed to respond to the participant's physical and clinical needs, while also considering their emotional, social, intellectual, and spiritual needs. This slide is simply another way of demonstrating those basic tenets. The DCC model calls for a shift in attitude from the traditional medical model, where the professional knows best, to the DCC model, which is also known as the person-centered model. For example, the problem is not the person's impairment, but the dependency that results from the attitudes and environmental barriers. That moves the locus of the problem from the individual to the environment. The solution to the problem changes from fixing the person, for most cannot be fixed, to barrier removal. The individual is not viewed as a patient or client, but as a participant, consumer, or user of service. Lastly, but very significantly, the control is shared between the professional and the participant, with final choice lying with the participant. If you reflect back to the vignette of James Lebrecht, I think you will see all of this referenced in his comments. At this point, we would like to show another video, and again, turn on your sound if you'd like to listen to her talk. We will hear here from Karen Schneiderman. She is currently the Director of Advocacy at the Boston Center for Independent Living. As with Jim, she was born with spina bifida. She grew up on the East Coast, went to college on the West Coast, and then returned east for work.
I mean, there are two classes of people. There are the professionals and there are the patients. And it doesn't matter who you are or what you are. And in fact, I think that if you express either a strong opinion or you appear to be intelligent, I think sometimes that's used against you because it's like you're engaged in a little warfare with the medical community. I understand the need for medical expertise, but I think that there are some areas where the person with the disability needs to be consulted and trusted to have the best either solution or something that will prevent things from getting worse or some new problem arising. They do not understand that they have certain skills and those skills are to be respected, but that people with disabilities have their own skills as it comes to using, experiencing their own body, working with their own body, taking care of their own body. And if we don't work collaboratively, the health care will break down.
And I hope you're getting the point. We're trying to model here listening to the participant. They are the ones who are living with it, who have the history, and often bring very important insights into where to go from here in terms of what their needs are. I think these vignettes and the future ones we will show, most of whom will be from the DREDF website, help model this interaction. The DCC model evolved from a few pioneering programs in the late 1990s. These programs matured and revised their model Components were adopted more broadly by health plans and health systems. This model has evolved into what has become known and recognized as best practices. The DCC model was developed by those involved in the pioneering organizations and was released in 2013, following input from subject matters and experts and field testing by several health plans. It is being revised to reflect the experience of the last several years and further development of the field and practice. This slide contains a diagram of the core values of the DCC model. I won't go further into being participant-centered, for I've been addressing this throughout the webinar. Respect for participant choice and dignity is sometimes challenging for providers. Most of us were trained in a skill or a profession and have gained specific knowledge. We have been expected to impart that knowledge on people, telling them what we think is best for them. But that often backfires, resulting in frustration for all involved, a breakdown in trust, and reflects a disrespect of the individual participant. Most importantly, it seldom brings about the best outcome. We have provided some webinars in the past on this subject, which you can find at the RIC website. Thirdly, elimination of medical and institutional bias is also a hard concept. What we're addressing here is a judgment or honest belief that an individual may best be taken care of in a certain setting, such as a nursing home or group home. While that may, in fact, be true from a purely medical perspective, it will certainly not be successful and can be inconsistent with if it's inconsistent with the goals and expectations of the participant. In summary, people with disabilities have unique needs and challenges with the healthcare delivery system. The DCC model requires a change in mindset and in practice and serves as a tool to help providers meet the unique needs of the population. Based on user feedback and the experiences and developments of the field, we have restructured the DCC model into 7 pillars of disability competency. As you can see, they start with the basic tenets of the model to participant engagement, access, primary care, care coordination, long-term services and supports, and behavioral health. I will briefly go through the remaining slides, giving a little more attention on each pillar. We have focused on this pillar throughout this webinar, so I won't go into it any further at this point. The second pillar focuses on participant engagement. To build trust, we suggest starting off by asking the participants to describe themselves and their life. Ask what is important to them and what they want and need. Participant engagement is not just limited to effective communication with the participant, but also with the participants' family members and other caregivers. This very seamlessly leads to a comprehensive assessment with a level of trust that will facilitate open discussion. The third pillar focuses on all aspects of access, which is perhaps the greatest barrier to care experienced by persons with disabilities. The DCC model describes access in the following terms: attitude, biases or stigmas associated with disabilities; physical, that's the most obvious access barrier, and it follows the requirements of the ADA and the Olmsted decision. Equipment access. That's exam tables, scales, and X-ray and radiology. Communication, that is interfacing with the participant, such as using interpreters for those who are hard of hearing or deaf. Service access, which refers to referrals and need to make sure that those who are the source of the referral also will be able to meet the needs of the individual. An example of this would be referring someone to an ophthalmologist, and that ophthalmologist's office obviously needs to be accessible, and their machinery needs to be able to be used by someone who is in a chair. And lastly, programmatic, and that is ensuring there are no systemic barriers to receiving appropriate care in a timely manner. The fourth pillar focuses on the provision of primary care. Disability competent primary care has 6 key components. Enhanced primary care with home-based episodic care capacity provided by a physician or nurse practitioner. The focus of that is to be able to capture avoidable episodes of illness. Focus on early intervention to prevent complications or exacerbation of chronic conditions. 24/7 access of informed and knowledgeable clinicians with electric health record capability. Ability and willingness to partner with the care team. Inpatient care management with aggressive transition planning and follow-up. As we all know, that's often where the greatest difficulties occur. And lastly, accessible physical facilities that ensure adaptive equipment and flexible scheduling. The 5th pillar is care coordination. Relational care coordination is a practice recognizing the participant is the primary source of the identification of care goals and priorities. Key components of this pillar are identity of risk, requires informed decision-making, team-based care with competency in primary care, nursing, mental health, and community-based services. Note here, I'm not necessarily saying people's professions. I think what's important is that they have the competency in that area. So, primary care, a physician, nurse practitioner, physician assistant are all possibilities. Sometimes some IDPs have a community-based services professional or social worker who also has expertise in mental health. So that could be one person. So the issue at hand here is that it's team-based care with those competencies. Comprehensive, timely assessment, and reassessment. Reassessment is based on any time a change in condition is experienced by the participant. Personalized plans of care incorporating the individual health care goals and preferences. And lastly, but perhaps among the most important components, is management of all transitions with clear communication and accountability of roles. The 6th pillar focuses on the provision and integration of long-term services and supports, requiring flexibility and care planning. This pillar includes ensuring participant choice in where and how they live, personal care services using either person-directed or agency model, equipment purchasing, fitting, seating, training, and maintenance clinics, enhanced independence via medically or functionally necessary equipment and technology, and flexibility to use alternatives in lieu of traditional home-based supports. Lastly, the seventh pillar is focused on identifying and addressing behavioral health needs and is considered an integral component of comprehensive disability competent care. Included in this pillar are mental health issues and their impact on the participant, substance abuse, and chemical dependency. In conclusion, disability competent care is just like any other care, but it additionally requires an understanding of the experiences of living with a disability. With this understanding, practitioners and plans can establish a relationship with each participant, and together they are able to develop a course of action. I worked with a medical director in Minnesota who said the most important tool our staff brought to our services is the relationship we were able to establish with each and every participant. He said without it, we would not be able to meet their needs. With it, we can together accomplish the goals they haven't identified. In summary, the DCC model requires interacting with the participant as a partner and treating them as an individual, not a diagnosis. It is participant-centered, eliminates medical and decisional bias, and respects their dignity of risk. Becoming proficient in understanding the experiences of the individuals you work with is the first step to becoming disability competent. We would now like to open up the presentation to your questions. Please use the chat feature on the lower left-hand side of your screen to any questions about the content of this presentation. I'm now going to turn this over to Jesse Nikolak from the Lewin Group to bring us the first audience question.
Thank you, Chris. So we've had a couple questions come in throughout the presentation. First here, going back to the beginning of the presentation, what clinical category does cognitive disability fall under?
That would traditionally, it depends on it depends on how you look at it. We look at it from a functional perspective. So how is it getting in the way of the individual, the ability to function? Traditionally, it could be in the category of persons with developmental disability or intellectual disabilities. It could also be subsequent to a brain injury. But again, we're trying to move people away from thinking about diagnoses and move towards thinking about the so what part of it. So what's the impact of that limitation on the person's life? Because that then is our job in helping them be functional.
Thank you. Okay, the next question we have that came in here is asking for an example of home-based episodic care capacity.
That's a great question, and that's among the hardest to put into practice. I have several examples that I think would get at that. So, the individual, let's say it's an individual with quadriplegia. The individual is noticing that their urine is getting cloudy. So, that's a sign. They've lived with their disability for several years. They know that that likely means they're getting a urinary tract infection. So the usual way to handle that is they would call their care team or their primary care doctor. I mean, historically, without disability complex care, they call their primary care doctor and hopefully get an appointment. Likely it would be days off. And then they'd have to try to get transportation to get there. Often for a quad, the cost of transportation is several times more than the cost of the care. And so the other factor in mind is with people with quadriplegia, often they're going from being stable to a systemic infection could easily be 24 to 36 hours. Whereas many of the rest of us who get a UTI, we can kind of push through it for 3 or 4 days, do our home remedies and all that, but we're not we don't go south as fast, shall we say. So what we need in this case is to get care to the individual quickly. That can be done a couple different ways. One way would be a primary care practitioner going out to the house to diagnose and begin treatment. Another way would be to have an arrangement with a lab, that the lab or nursing, it can be a skilled home health agency, would go and get a sample within 24 hours, get it tested very quickly, and that the physician or the primary care practitioner would look at the results and then order a antibiotic and get that to them so they start treatment within 24 hours. That last alternative actually avoids a primary care doctor needing to go to their home. So that is one example of home-based primary care. What the issue here is you have to know the person. One more example with the UTI that we actually did in Minnesota some, many people with spinal cord injury would get repeated UTIs. Usually they would be the same, they would need the same prescription as a result of the UTI. So what we would do is we would give them a supply of that antibiotic to keep in their house. We would then ask them to not take it until we got the lab results back to confirm that they were getting the right antibiotic. But then we're saving all the time of getting the prescription or to a pharmacy and getting the pharmacy to deliver it to the individual. So those are all examples of primary care intervention that keep the person, out of a primary care clinic that may or may not be accessible and timely, keeps them out of the ER because the infection has become much more serious. And as we all know, once you get into an ER or a hospital, it often becomes more problematic.
Thanks, Chris. Just a very quick follow-up to that question you were just answering. It's a little bit specific, but the home-based care that you just described, is that Medicare, Medicaid billable?
If the provider is in a capitated plan, they can enter codes and all of that. If they're in fee-for-service Medicaid and Medicare, it depends on their license, the state they're in, and the contract they may have with the payer, whether it's the state or a health plan. So if to bill straight Medicare for that home-based care, it won't reflect the added cost of delivering the care at home, because obviously it's more expensive to get a practitioner out to the person's home than to have all these people lined up in the practice to be seen.
Great, thank you. Next question we have here, could you further discuss adherence to a treatment plan and the dignity of risk?
Yeah, if you go to the RIC website, you'll actually see a couple webinars where we talk about that. They are literally just dedicated to the dignity of risk. We also have a couple first-person stories. One is John, and I can't remember the other person's name, but they also talk through that very concept. So let's take an obvious one. I think the two that we have up, one's around diabetes, and another one may be around smoking. But let's take the obvious one, smoking. We all know smoking is not good. And for a doctor or a care coordinator or mother or a spouse to tell the person it's not good for them and they should stop is likely not going to have much of an impact. So what we're talking about here is not that we just simply say, oh well, okay, that's just the way it's going to be, and ignore it. What we do is we keep talking to the person about it. We keep engaging with them, not in the initial visit, not necessarily even in the subsequent visit, but over time. Next time they get a cold, maybe bring it up then and say, you know, the way the cold is lasting longer than it may for others is it could be related to your smoking. Obviously the same for pneumonias and bronchitis. So it's really more about education and engagement is what that's about. We try to stay away from the term compliance because it goes back to we know what's best for you. And with a lot of people, I know another person with a disability who needed a surgery. The person smoked a few cigarettes a day. So we're not talking a large amount. The surgeon, and it was a relatively minor surgery, said, I won't provide surgery until you've been off cigarettes for 6 weeks. Because there is a correlation to nicotine and healing. This person also struggles with a severe mental illness. So going off cigarettes for that person while they're facing the surgery and struggling with serious mental illness, the greater risk was cold turkey from the main coping mechanism that individual has for their severe depression. So that's another example of the engagement with the person. In that case, we talked directly with the surgeon, explained the situation, and he said, yes, I understand, I will schedule the surgery immediately.
Great, thank you, Chris. We have another question that's come in here from the audience. Do you see primary care practices or primary care physicians having to add staff or changing their structure significantly to effectively do disability competent care? And do you assume they will be open to this change?
Yes, and our experience is, and we have a webinar, and a Medicaid medical director from Aetna is going to be talking about this. It's about engaging primary care, and I understand the question, and there's no easy answer. Our experience, and I've been doing this for 20 years around primary care, I'm not a primary care physician, but I've been interfacing with primary care, is the practitioners want to. They want to provide care to the people who need their care. The issue is all the systems around them interfere with that. An example is someone with a speech impairment. It takes a lot longer to do a physical than it would on me, who can talk very fast. So that's just one example. So it does take some accommodation. We'll be talking about that in webinar 3. So it is it does engagement of physicians. You need to try to develop a lot of support mechanisms to help with that. We have a brief, I believe it's up on the RIC website, on engaging primary care, and may I refer you to that. But another example is in the dual eligible plans that are growing in this country. The issue becomes one of what you need is you need the glue. You need the glue between the primary care physician and the care plan. Who's going to make that happen? Physicians don't have time to do that. So the question is, where does that care plan, that care coordination sit? Does it, many places, it is sitting within the primary care practice. So they're either hiring the care coordinators themselves, or the health plan is giving them additional money to hire them, or the health plan is placing people in key primary care practices. one common thing that we did when we started this 15 years ago is we looked at who are the practices that see the most people with disabilities. In other words, we try to follow our members. Where do they go? Because they obviously are going there for a reason. It may be as simple as that it's accessible, or it may be that they like the person. Doesn't really matter. Then make a connection there. The goal is to have champions within that practice, and you need two kinds of champions. You need a physician champion. Not that that physician will take everyone with a disability, because his capacity to serve people will shrink because they take longer and they're harder often. But someone who can serve as a resource to the other physicians in that practice or practitioners. The other person you need as a champion is a manager there, because a lot of work that needs to be done in primary care practices is around making sure you track accommodations. So when you're scheduling an appointment for the person, make sure that you reserve the large exam room with the up-down exam table, so that when the person arrives, you can actually serve them. And that's system stuff that you need engagement from a clinic manager or someone on that side of the shop to build that into their practice pattern. We will be talking about that a lot more in the third webinar here.
Thank you, Chris. And I think we have time for just one more question here before we wrap it up today. So we have one more that came in through the chat. How does care coordination for persons with disabilities vary from care coordination for other populations?
Yeah, it's, in some ways I would look at it. So how does that, I'm not quite sure what the person means by other populations, whether it's like, my guess is for someone who's geriatric, for someone who has Alzheimer's. So if you start an adult, don't need care coordination because I'm capable of doing that myself. For other populations, the issue is you need to, first of all, stop and understand who they are and what their needs are, and then accommodate those needs, whether it's Alzheimer's, whether it's whatever the other issue going on. It really, care coordination is care coordination. Your competency, you may need to understand a little more about certain things. I, for one, don't understand dementia very well, so I would certainly need to bone up on that if I wanted to be a care coordinator with that population. But the foundational skill set that I would need to bring is the same that I would bring within the disability competent care model.
Thanks, Chris. So with just 5 minutes left, I think we have just enough time to wrap it up with the remaining slides then.
Great. In conclusion, the disability competent care model is just like any other model, as I stated in the last question, but additionally requires an understanding of the experience of living with disability. With this understanding, practitioners and plans can establish a relationship with each participant and together develop a course of action. Thank you. Excuse me, I'm losing my.
Thank you, Chris.
Yes. I think the slides and my narrative aren't matching perfectly here, so I'm sorry about that. And I think we are at the end of our time anyway. So just in closing it, we appreciate everyone's questions, and we're going to send this back to RIC, and the narrator. Again, if we'd like to call your attention to the resources that we have online at the Resources for Integrated Care website, including the Disability Competent Care Self-Assessment Tool. I hope you will join us at least on today for our second webinar, Disability Competent Care Participant Engagement. Again, I would like to thank the Center for Medicare and Medicaid Coordination for sponsoring this webinar and the entirety of the Disability Competent Care work. Thanks for attending.